tonight's ASCP Town Hall. I'm Dr. Blair Holliday, the CEO of ASCP. For the past 3 months, we've brought you almost a dozen of these live Town Hall events in an effort to keep you informed by the important changes within the pathology and laboratory medicine community as we navigate this tumultuous pandemic. In addition to this pandemic, however, since May, Americans have been embroiled in a highly charged discussions about race and equality. Both these discussions and the pandemic have led to conversations at every level about health equity and what it means to be a Black patient, a white patient, Latino and Native American, Asian, gay, transgender, non-binary patient and healthcare environment today. So tonight, we're going to tackle this discussion from the perspective of the laboratory. And as we look how the laboratory plays an important role in improving healthcare equity and how diversity can play a role in our laboratory workforce and how we can translate this into better health equity for our patients. Let me set the stage for you. Over the past decade, diversity and inclusion has become a topic of note across industries and in particular healthcare. And there are massive health disparities among ethnic and racial groups, often starting from access to care and ending with worse health equities when compared to other populations. Recent data has shown that 10% of African Americans still don't have health insurance, compared to 16% of Latinos and 7% of Asian Americans, 14% of Native Americans and Alaskan Natives. And while the Affordable Health Care Act extended coverage to many Americans who previously were uninsured, 30 million people remain uninsured. And about 15 million are those people that we're going to be talking about. People of color that have healthcare equities that demand responsibility. Now, when there is disparity in access to healthcare, it impacts all parts of healthcare, from outcomes to the cost of medicine. It's estimated that, for example, disparities can rack up upwards of $100 billion in excess medical care costs. So there's been a movement to eliminate healthcare disparities and provide better access, eliminate access to barriers by improving outcomes. And these disparities have shrunk, sure, but they haven't been eliminated. And the fact remains that different patients experience healthcare differently based on the color of their skin, their sexuality, their gender, or even all of these factors combined. And the need to acknowledge diversity and inclusion of the population really doesn't stop with patients. It needs to be acknowledged in our workforce as well. Research shows that diverse workforces create better performing organizations. In fact, the McKinsey study of Diversity Matters showed that gender diverse companies perform 15% better than those that were not. And ethnically diverse companies, 35% better than those who were not. So when it comes to healthcare, having a diverse workforce is even more critical. By 2050, people of color will make up more than half of the population of the United States. And we've seen research that a diverse healthcare workforce stems the tide. A diverse workforce is associated with improved access to care for racial and ethnic minorities, and it's associated with a greater patient-clinician communication. And it's associated with improved educational experiences for our students and all of the professional careers. Simply put, if the population we're caring for is diverse, so should our workforce. The issue of inequity, race, and gender equality in healthcare isn't always easy. It's certainly not always comfortable to talk about, but it's a topic that we must talk about openly and honestly if we expect real change. So joining us tonight for our discussion around these topics are three outstanding panelists who are well-versed in health equity in the laboratory. Please allow me to introduce Dr. Marissa White. Dr. White is Assistant Professor of Pathology, the Division of Surgical Pathology, Breast Pathology Program at Johns Hopkins University School of Medicine. Dr. White, please say hello.
Good evening, everyone. Thank you so much, Dr. Holliday, for the introduction, and thank you for allowing this town hall to happen. It's a very important conversation, so thank you.
Thank you, Dr. White. Secondly is Dana Bostic, who is an assistant professor at the University of Kansas Medical Center, the Department of Clinical Laboratory Sciences. Dana, say hello.
Hello, good evening, everyone. Thank you for this opportunity to be a part of this very important and timely conversation.
And Dana, thank you as well for being part of our Commission for Professional Development.
Thank you.
And lastly, we have Matthew Krasowski, who is a doctor over at the Walter Bering Professor of Clinical Education. Dr. Krasowski is an MD PhD at the University of Iowa Hospitals and Clinics. Dr. Krasowski, please say hello to the audience.
Hello, thank you very much for the opportunity.
Thank you. All right, now before we get involved in our Q&A with our panelists, I want to remind the audience that you can submit your questions to the Q&A function at the bottom of your screen. And now I'm going to show you the compliance language. Okay, so let's get right into it. And let's start by laying out the foundation and understanding what we mean when we say health equity. Dr. White, let's start with you. What does the term health equity mean? How does that translate through the laboratory? And how does diversity of both biomedical and professional workforce, how does that affect health equity?
So I think in the simplest sense, health equity is the ability for every single individual in this country and around the world to achieve their fullest potential and to live their fullest, healthiest life. And that means that no matter what your socioeconomic background, you have the ability to be healthy and to have well-being. So in the simplest sense, health equity is health for all. In terms of what we see in the laboratory professions, I think it's challenging because we don't see our patients on a daily basis. Oftentimes we see their samples, but we're not actually faced with our patients and we're not seeing the direct impact of health inequities and disparities. So it's challenging, I think, for us as pathology professionals to think about health disparities and how it affects our practice. But I think we'll delve more deeply into this conversation today about what we as pathology professionals can do, because there's numerous aspects that we can impact positively to improve health equity for our patients, even though we're not directly seeing them.
Ms. Bostic, I'm going to ask you the same question. When you think of the word health equity in your career, tell me how it was defined and how you define it now.
I have to say, honestly, I think that's where the gap may be, especially when we talk about laboratory scientists in particular. We don't heavily talk about health equity within our curricula so much. Most of the emphasis is on competency, clinical competencies, and technical skills. But when I think of health equity, as I had come to learn that terminology, similar to what Dr. White just mentioned, access for all. Fair access to healthcare and just equal access to laboratory testing in particular. If you look at the way that some of our testing panels are structured, or even just specific tests, I know recently there's been publications about the EGFR, for instance, with that bias there, where into that equation or calculation you talk about Black versus non-Black, whereas that's not fully I would consider health equity in that sense of how that result can potentially impact a patient's ability to be placed on a kidney transplant list, or how they're categorized, or how they're treated. It may not be an accurate depiction of the full picture of what's going on with that patient. And so as I've come to learn this in the work that we do, it's exactly what Dr. White just mentioned. Fair, equitable in every layer of what we do in healthcare, including laboratory testing.
Dr. Krasowski, define health equity for me.
Yeah, I think it encompasses a number of things. I mean, it's access to healthcare. It's having access and ability for treatments, and that people are treated equally. I mean, I remember back, I started med school in 1994. Even back then, they were talking about studies with standardized patients, the exact same scenario, different color patients, and different treatments are recommended for each. And I think even 25 years later, I mean, we're still having a lot of these conversations. In terms of the laboratory, I think the areas in the laboratory that do directly interact with patients, like phlebotomy, cytology sometimes, transfusion medicine, there's a lot of opportunities, for providing equity. One just very simple example, which I never imagined would be so challenging, was preferred name. Just getting that into our EMR, getting that scripted, and that's really important to some patients. That's for transgender in particular, but some patients, it's just nice. You're addressing them by how they prefer to be addressed, not necessarily their legal name. And so I think there are things like that that, can really make a big difference as well.
Ms. Bostic, I'd like to get your perspective on laboratory practitioners. As Dr. Krasowski just said, they're largely removed, with some notable exceptions, of course, as he mentioned, cytopathology and phlebotomy and others, but from direct patient interaction, how important is it for the laboratory staff to understand the diversity of their patient population?
I think that speaks more to awareness. Just knowing that there is a person, that there's a human being on the other side of that tube, and understanding how our work, how our expertise contributes to that complete or whole patient picture. If you look at, just from the phlebotomy stance, that's still a part of the laboratory patient facing. And it all starts with that pre-analytical phase, the proper collection, the comfort and trust level being established by that front line with the patient. And so that builds confidence in the work that we do and the results that we generate. But we also have to look at, too, as you mentioned, there are some exceptions, like with our doctorate in clinical laboratory science, or a DCLS. That's one of the reasons why we're advancing our profession, to include these additional roles, to be more patient facing and to be at the bedside, to once again create that awareness, but also create that line where we are passing it on and being more face to face with our patients, so that we can spread that awareness to the rest of the members of the healthcare or laboratory team.
Dr. Krasowski, I'd like to go back to your comments a few minutes ago. I find that intriguing when you mentioned the issue around direct interactions with patients that both you and Ms. Bostic have discussed. So tell me, how can we be more inclusive in our direct interactions with patients, such as phlebotomy or transfusion medicine? What are some general ways in which we can be more inclusive? Tell me your thoughts.
I think there are ways, just in terms of just sort of general scripting and how you address patients, address them respectfully, be consistent in that, and that you're not treating certain groups differently. Other things that we face are actually coming from the other direction. So like in Iowa City is predominantly white, and most of our phlebotomy staff is actually from Middle Eastern or African countries. And they've encountered patients who sometimes say that I don't want someone who's not white drawing my blood. And those type of ones can be really challenging. I mean, we'll get a supervisor involved, and sometimes even a little humor there. We've had a supervisor who comes in and says, well, I can draw you, but I'm not very good at it. She's really, really good, and you want her to draw. And I think, like in our department, we had like a grand rounds that was talking about different areas of diversity. And we've actually found, I mean, for example, phlebotomy, a lot of the staff were there, pretty recent immigrants to this country. And they would say, hey, this was never in their curriculum. And so being exposed to it, being exposed to the concepts was actually really, really helpful, because they hadn't seen a lot of it. And, medical schools have a long ways to go, MLT programs, MLS programs, there's a lot of things to do to incorporate these concepts and really make them, I think people become very comfortable with them.
So Matthew, I understand you quite a research focusing on transgender. Tell me a little bit about the regulatory, legal, billing challenges impacting transgender patients within your perspective, your laboratory.
Okay. You cut out there for a second. So it was regulatory, legal, and billing challenges with transgender. So,
Correct.
I mean, there's a number there. I mean, one is that the ability to change your legal gender varies across states. And so For example, I mean, some people can actually change their gender. And if they came to your hospital and registered, they would be that gender. And if you had reference ranges that were different by male and female, you'd be showing it for that. And for some tests, that actually would probably work out well. Other tests, it could be misleading because it may not flip to the opposite gender in that case. The billing stuff is, you actually find that there is so much billing that's constructed that's actually gender defined. You know, pregnancy encounters are one, prostate screening is another, and that can lead to a lot of complications where you run into blocks in the system. The other is that I think for billing, a lot of times billing continues to use legal name and not the patient's preferred or you know, their name that they've adopted. And so I think all those things are factors that come in there. And I think, you know, there's been a lot of talk about how would you show the right reference range when electronic medical records are all handling gender and sex in different ways. Reference labs, for example, may not have access to some of that information. So that's an area I think that's really going to evolve in terms of how do we best show the right reference range for patients and then navigate all these other issues.
And have you come up with solutions within your laboratory to address these and to ameliorate the difficulties that you've had?
Within our electronic medical record, patients have the ability to indicate their sexual orientation, gender identity, preferences, and if we find a mismatch between birth sex and gender identity for certain tests, then we suppress the reference range and add informative comments. That's one way to do it. If there are tests that you know that, a great example is this hemoglobin and hematocrit, under either testosterone estradiol treatment, it flips completely to the opposite gender in terms of range. There's a case actually where it would be appropriate if you really knew that was the patient's gender, to show that reference range. But this is really complicated because electronic medical records differ between institutions, and it does get complicated. But I think you're going to start seeing a lot more literature come out on this, because it's a topic that it's one of the most common questions I've gotten after we publish in this area is like, we're at hospital X, we'd like to do this. What are our options, basically?
I'd like to ask Dr. White a little bit of her perspective in your laboratory, Dr. White. Are there clearly visible efforts to achieve health equity and diversity among the workforce within your laboratory, or even across the hospital system altogether?
Yeah, that's a really good question. So we at Hopkins as an institution have a broad institution-wide push to focus on diversity, inclusion, and equity. And everything has kind of been pushed to the forefront with the more recent events. But we have a new chief diversity officer and a dean for diversity inclusion. We have a house staff diversity council, and that's just institution-wide within the medical institution. As far as within our own individual department, we have diversity committees for both the faculty and trainees, and then for the actual lab staff as well. And both our internal pathology department diversity committees have our own individual pipeline initiatives to support either, on the faculty and trainee side, trainees pursuing interest in pursuing a career in pathology medicine, or on the staff side, local high school students to encourage them to pursue training in local histotechnology programs, or to pursue higher level graduate level education. So it's both departmental wide, but then also institution wide. I think that's so critical, where any single initiative needs to be supported by the institution as a whole. It has to be a team effort.
Dana, let me ask you to weigh in on the same conversation. What are some of the opportunities for enhancing cultural competence in the key areas within your institution, or just any key area of diversity, equity, inclusion within laboratory medicine? Tell us some opportunities.
I feel like I'm in a unique location because we do have this bridge between academic institution and the hospital or the medical center. And so even though they're two entities, we do come together as one, especially in how we communicate across those lines. So for the academic side, we have our Vice Chancellor for Diversity, Equity, and Inclusion. And from that office flows a variety of teams. We have the Diversity and Inclusion Cabinet, which is representative of all the schools that are a part of that campus. So School of Medicine, School of Nursing, School of Health Professions. Also within each school, we have our diversity, equity, and inclusion committees. And so I just came off of my term as chair for our diversity, equity, and inclusion committee for the School of Health Professions, where collectively we would reach out to individual departments, address any immediate needs or concerns that they had, especially with regard to integrating diversity into the curriculum. From a medical center stance, I would say it's very important, or we recognize the importance of starting early, in that it starts at the academic level, preparing better professionals, I would say, going forward, or bettering them for today's needs, especially when it regards diversity, equity, and inclusion. You know, as I mentioned before, in my academic experience, it didn't come across as intentional, whereas at our institution now, it is very intentional that we do want to, you know, make them more well-rounded healthcare professionals that will be contributing to healthcare.
And Matthew, tell me about within your institution, what are some key areas of enhancing competence? You mentioned it's a uniquely white area of the state, the country, and that you run into barriers at times. What are some opportunities that you can share with us within your own institution?
I mean, there's been a number of initiatives. A lot has been focused on education. And I think more recently, a good example of this is a focus on the medical school curriculum. You know, what I've seen, I guess, over 25 years, there's a lot of the way things are taught in medicine that just sort of seems they've been taught that way. And you'll see diseases where it's consistently mentioned, okay, well, this race gets it at a higher rate than this race. And I think people had not really asked the question such as, is that information important? Is that something you need to convey for it? Actually, the estimated glomerular filtration rate with creatinine is one that I think people have debated over the years, and recent events have finally brought it to the light to say, how strong is that data actually? Is this really the right approach? You know, in addition to all the challenges of trying to display those values. So we've had trainees that are involved in various like quality improvement projects. And I think when there's more practical efforts to look at, to work on these things, I think that helps a lot. There's a tendency to sort of say in lab medicine that, well, we're kind of behind the scenes. This isn't always as relevant, but it is really relevant. The other conversation I think can be a challenging one, which is that with our graduate medical education is also how trainees perceive that they're treated. Some have come to the country fairly recently, some like in Iowa, some have been here their whole lives. And we will get comments from trainees that some feel that they're treated differently from other trainees. And I think faculty sometimes aren't aware that they're doing it, and having sessions where these things can be discussed. And I think particularly, you know, if it's discussed in a way that's making people uncomfortable, that's probably what it should be doing, rather than just a series of lectures or online trainings that you look at. Because I think a lot of people tend to get defensive or have, you know, about this topic, but it's a very important one to have.
Dr. White, I'm interested in your perspective as well in terms of those who are underrepresented in medicine and some of the challenges faced by these students in their pathway career in pathology and lab medicine, both in training and practice. What are some of the unique challenges that you see, and what are some of the solutions that you could share with us?
That's a good question. So I think I'll start that by commenting that I intentionally went to a historically Black medical school because I wanted to have an inclusive medical education. I remember doing my interviews at majority institutions, and there was nothing that was overtly biased, but I just felt like I didn't feel included. And so I intentionally went to a historically Black medical school. I went to Morehouse School of Medicine so I can have a more affirming experience as a Black woman in medicine, because, you know, looking at where I work now, there's a very small handful of African-American faculty within individual departments. So looking at, you know, just the medical student experience, when you're at a majority white institution and you're looking for, you know, allies, it can be challenging. I mean, medical education is difficult enough to start. And then you have to face the challenges of having, you know, faculty that quite frankly trained at a time when, you know, some hospitals were still overtly segregated. Thinking about individuals that trained, back in the 70s or 60s. Some of them are still on faculty, and certainly, people are more inclusive now, more aware of their biases, but it still happens. In terms of pursuing a career in pathology, I think while pathology is recruiting African Americans and underrepresented minorities at an equivalent rate compared to other graduate medical education specialties, there are significantly fewer underrepresented faculty and pathologists in practice. And I think that's the challenge, where if you have an underrepresented minority student interested in a career in pathology, they're just not seeing individuals that look like them, that have a similar shared experience. And we still face microaggressions, implicit or explicit bias, challenges negotiating, how do you be a Black woman in a majority institution? I'm being very, this is the first time in my life that I've ever worn my hair natural. And that's intentional. It sounds silly, but this is an intentional choice. Before this, I didn't feel comfortable doing this because I was concerned that someone would look at me differently or think about me differently. So it's challenging. And I think the most important thing that we need to do to change things in our specialty is to expand the pipelines so that we can recruit and then retain pathologists underrepresented in medicine.
Well, first of all, your hair is beautiful. And second of all, we all envious of your hair, okay? I mean, let's face it. That is, you win the award. Now, I want to go straight to pick up on something you said, because it is a woefully inadequate issue, isn't it? So it's, we know that more than half the laboratory professionals are women. And the laboratory has a larger proportion of minorities than other general population, but for pathologists, less than half are women. Actually, Blacks and Latinos are woefully underrepresented, as you indicated, and that given more diverse laboratory professional community, as you mentioned, could really help pathology leadership improve in terms of their chasm and working together. But I'd like to flip the question a little bit, and actually, if you could please, any of you jump in on this one. What are some of the negative impacts of this discordance for laboratory staff, pathologists, patients, laboratory professionals? I'm interested in finding out what have we seen negatively, and what can we do to improve that? And we can start, actually, Marissa, if you want to start with the negative impacts, feel free, but I'd like for all of you to jump in on this.
I mean, I think fundamentally, when you don't have diversity, you're not getting new ideas, and you're not allowing those that have great ideas to realize their fullest potential. I think the most poignant story, close to us at Hopkins, is the story of Vivian Thomas. For those of you who aren't aware, Vivian Thomas was retired as the director of the surgical research labs here at Hopkins, but he spent his entire career working in the research labs. Worked with Dr. Blaylock and Tausing to make the Blaylock-Tausing shunt to treat blue baby syndrome. He could have been a phenomenal cardiothoracic surgeon, but never had that opportunity. And he contributed so much to cardiothoracic surgery just as a research technologist. What could he have done as a surgeon? And that's the tragedy of the lack of diversity, where you have individuals that are phenomenal and just aren't able to realize their fullest potential and contribute as much as they can.
Dana, what are your thoughts?
I'm really big on diversity is our strength. And when we don't have diversity, we don't have the true strength of the organization that we need. I think one of the main negative impacts that I've seen is just losing really great, talented people from the profession altogether. And to lose people, especially to other professions, it's detrimental to the workforce that we are trying to build in the laboratory. As Dr. White just mentioned, having that diversity in the lab really creates an opportunity for us to learn from each other and about each other. And in learning from each other, we learn more about our diverse population. I know I learned about different holidays, observances, beliefs. And, when a patient was introduced with a similar background or a similar set of beliefs, it was easier to understand and apply that in our plan of care for a patient. But I'd say most importantly, just losing people, losing really talented, great, effective people. And we need people. We hear about other healthcare professions experiencing shortages. We're having a very bad shortage right now on both sides, laboratory and pathology, and just informing those that are in the laboratory, like medical laboratory scientists that do want to, move up the ladder or move beyond the bench in the profession. If, just mentoring and speaking to them more about opportunities in pathology. A lot of them don't realize that they really do have a great foundation that would lend well to becoming a pathologist. So I think just working on that, some more retention within the profession, within the workforce, um, that's where I've seen, I would say, most of the negative impact.
And as an educator, I understand that you're working on your doctorate degree in education. As an educator, what messaging, what poignant messaging can you give to your students to paint the way for the future for diversity and health equity?
I would have to say it's really awesome, this generation of students that we have right now. They're very vocal. I think they're more conscious of what's going on in the world, and they're quick to call things out. And especially as an educator, I've had students speak to, especially when I talk about blood donation requirements. That's always a heated or a fiercely debated conversation, a welcome debate. When they hear about certain restrictions or certain guidelines, they want to know why. They demand an answer to the why, and they want to understand why that answer doesn't make sense. But my charge back to them is, coming into this profession, you are a patient advocate as well. And if you feel like things are wrong or incorrect and not as inclusive as they need to be, you are in position to voice that and contribute towards, changing or improving that picture. We all have that obligation, going into healthcare, because in speaking up for our profession, we're also speaking up for our patients and the diversity that we want to see. And so as an educator, just once again, encouraging that in learners, encouraging them to have a voice, encouraging them towards promotion and advocacy, and being engaged so that we can make those effective changes as we need to.
Dr. Krasowski, you're in an academic medical center.
Yeah.
You spend time interfacing with students. What is your message for inclusiveness and diversity and creating a future that's different from perhaps the ones that we have all been involved and unfortunately had to see the repercussions? What's your impact statement?
Well, one thing I've noticed, I've been a course director of a first-year medical school course, is to echo on the comments that just came, which is that students actually are expecting more. It's like in the last 5 years is where I started to see students say, you know what, the composition of lecturers in this course does not seem diverse. It's all male, not enough female. It doesn't. And I think diversity within the profession makes a huge difference. I mean, recruiting people to become pathologists is already sort of a difficult battle, because it's in medical school, it's not a heavily emphasized specialty. If students have a really good experience in a pathology-based course, that helps. But all it takes is some negative comments that could steer them away from it, or away from medicine altogether in an earlier phase. Oh, it's a lot of years of training. It's going to take a lot of time. Why would you want to do that? You can do. And so, I think having role models at all different levels to just let people know what are the options out there, what are the advantages. I mean, there's pathology in all its forms has so many advantages as a career. I mean, I've loved it, but you have to get that message out there, and let students see that.
I'm sure that each of you have poignant stories, as Dr. White shared with us, and I'm sure there's folks in your mind that have not had the opportunities that they should have been afforded, right? And I'm sure each of you thinks of that when you speak to those prospective practitioners. As I was listening to you, Dr. White, I was thinking about Henrietta Lacks. She was treated, with great healthcare disparity, but she is the reason why there's a cervical cancer vaccine today, isn't it? She's the reason why there's no need for the number one killer of females to occur anymore, because of her DNA lived on forever. So it is, in fact, a poignant story. I love the stories, and I think it would be an interesting an interesting exercise if we all shared our stories as part of the conversation, because that's what people relate to, isn't it? And I thank you for that. We are going to segue now straight into the audience participation, and we have a few questions already lined up. So let's just get started, and let's start with a question for you, Dana. And this is a question from Andrea Jensen. Andrea Jensen asks the question, how can laboratory educators best help MLS curriculum to be more inclusive? And what can we do, if I compare this, to help our physician practitioners understand the role of that healthcare parity as well? Thoughts?
I would say if you're at an institution where you have resources, there is an office for diversity and inclusion, becoming more connected with that office to see what resources and services are already offered. In addition to that, I would say educating yourself is really important, especially doing some more reading, doing more research on what other programs have done to curricularize, I would say, diversity and inclusion. I feel like laboratory education is really rich. We have a lot of opportunities to integrate this content into our curricula, especially when we look at blood bank, of course, is a juicy area for that. It's very easy to incorporate a lot of that content, even the historical context of things. I always spend my first lecture on the history of blood bank, how we got to where we are now, and all that history is not pretty, but it gives them a better or firmer foundation of, not just how we got here, but the sacrifices that were made along the way. And so just to once again bridge that to, you have to have this understanding to be able to be effective and contribute, especially within our role as laboratory professionals. But I think starting with looking at the resources you already have and looking at where you need to build and grow and where you can have those potential collaborations. Interprofessional education is an awesome vector for that, I would say too. There's great opportunity to incorporate a lot of that content within that space as well.
Dr. White, I think this feels like a question for you and Dr. Krasowski, but again, feel free to answer if you like, but it beckons back to the conversation that you introduced earlier, and that was around the inequity in terms of Blacks and underrepresented populations within pathology community at large, particularly in the medical school and recruitment into pathology per se. There's an anonymous attendee who was asking, why are residencies, pathology residencies, so underrepresented by Blacks as compared to other fields of medicine? And in fact, if you want to follow up to this question, I guess one would be, what can we as a medical community do to increase new residents in going into our field? Matthew shared with us what he thought, why he was passionate about the profession. Tell us what we can do, Dr. White.
I think the challenge with recruiting individuals to go into pathology is partly because of the transition to the integrated curriculum, and I'm sure Dr. Krasowski might have more insight into that. But so I, for example, at Morehouse School of Medicine had a dedicated pathology course that was an entire year long. We had microscopes and slides. Most of the pathology education now in the integrated curricula consists of digital slides that are annotated, and it's a small minor component of the course. And the students maybe spend a couple of hours or something a week. So I think pathology has lost its visibility, and subsequent to that, we have fewer individuals going into pathology residencies, and that makes the challenge in increasing diversity in pathology that much more challenging because you're already starting off with a more limited pool. But what we can do as pathologists is do active outreach, and that's partly of what we have done at Hopkins. We've established a combined outreach program and a funded rotation for individuals underrepresented in medicine to encourage individuals to consider pathology. And the outreach is key, where we don't just go to the pathology interest group, we go to the entire class. We go to Morehouse School of Medicine, we go to Meharry, we go to Howard College of Medicine, because those are historically Black medical schools, and you're going to get the largest audience. And then we talk about different careers in pathology. And, again, we think about, going to these institutions. I remember my experience at Morehouse. There were individuals that, trained at Hopkins at a time when it wasn't that inclusive, and they were, victims of overt bias. And so, I had someone tell me, well, you might not want to consider training at Hopkins because my experience there was awful back in, whatever, century, back in whatever decade. So the active outreach does two things. It not only, introduces your institution in a better light, but then also, lets individuals see that, careers in pathology are more exciting and very diverse. And then the intentional elective programs are really key, because when you think about the inequities that medical students face, underrepresented students face higher levels of medical school debt and education debt as a whole. And so when you're thinking about access, when these students are thinking about, residency programs and doing debut electives, that becomes a real serious conversation that they have with themselves, because you're talking about, paying double rent for a month to go do an elective rotation somewhere else, travel fees. It becomes an incredibly inaccessible experience for a student that comes from a socioeconomically disadvantaged background. So thinking about ways to increase equity when we're trying to, increase diversity, it's really important.
Dr. Krasowski, I'm interested in your perspective as well. What can we do to increase the number of Black and underrepresented populations into pathology? Are there tactics that you would recommend, or are there ones that you have actually implemented?
I certainly agree with the outreach at an earlier phase. I think the challenge is, and I worked on putting a course together when our institution switched to an integrated curriculum. And one thing I learned in that process is that if pathology is not at the table in integrated curriculum, there isn't going to be much pathology in there. And we had reached out to other schools, and those curriculums become very influenced by who becomes course directors. If it's a pediatrician, if it's an internal medicine doc, if it's not, or a pathologist in my case, they're going to bring in their expertise. And ideally, you'd want diversity among specialties there too. Otherwise, especially pathology may hardly get mentioned, and a student could make it until third year, fourth year, and not even know that's a viable option as a career. And by then, it's pretty hard to convince someone that they're gonna go that route. So one thing we've done at Iowa is that we give all the students, we have limited time, but everyone gets a tour of our central laboratories. And I frame it as, hey, let's just look at what's behind the scenes. And a lot of them are like, we had no idea this is behind doors. And that's the reaction of general public. If you give them a tour of pathology space, they actually love watching the automated part of the labs. They also love watching, if you can, tissues getting cut in surgical pathology. Gross room may be a little bit ambitious because that may freak people out, but how things get onto glass slides, that's fascinating to a lot of people. But I think, yeah, having those experiences. And in the course, we also exposed to radiology, another area that it's not covered. They may not hear much about it until they hit clerkships. So, but yeah, I think getting some exposure to it helps, but certainly outreach in an earlier phase, because if they've already been told that pathology is not really a good career option, they're not going to consider it. I think the monetary issue is another one there, because you'll often see on a lot of listservs when we talk about residencies, and this not just pathology, but there could be inaccuracies there. Oh, if you go into pathology, you're not going to make money. If you go into X, you're not going to make money. Those actually have a lot of influence on people. And so having specialty specific mentors and advisors can really help to give people an accurate view of what's possible.
There are a number of our illustrious ASCP members, such as Dr. Carla Ellis and Dr. Valerie Fitzhugh, who have been looking at, well, first of all, their social media icons. Let's put it that way first. Okay, so they get the word out on the recruitment conversation and have the ability to help influence, at least, and in a very provocative way, get folks convinced that laboratory medicine and pathology is a great career choice. I don't know how anybody says no to either one of those. But the truth of the matter is, it is an uphill battle, and there's a lot of work to be done. Dana, what's your opinion on the lab professional side in terms of recruiting a more diverse workforce and getting folks interested in the laboratory professions?
I would say it's similar to the other points that have already been stated, starting earlier. And I think it's also about being intentional about, the school districts that we enter. All of them can't be the top district in the state or the top school district in the area. We have to go into those communities where diversity is represented as well and bring it to a younger audience. I know when I first started, we were starting with high schools. Now it's imperative to start with middle school. They're already selecting their tracks at some institutions as early as the fifth grade or the sixth grade. So really getting in front of those groups, giving them hands-on opportunities. They don't want to be talked to or lectured to. They want to get their hands in it. It always amazes me how they love playing with urinalysis and and of course blood typing and all those awesome things. But at similar points, getting their hands in it, giving them the opportunity to see it, giving them the opportunity to shadow. I know with my niece, when she was in middle school, I actually got her a lab tour, and she's in school at Auburn studying medical laboratory science, all from her aunt taking her to a lab when she was in middle school. And so just really being intentional in getting in front of those groups, building partnerships, community partnerships, and also, bringing them to where we are. I know we can't do that now with COVID as much, but that's where we have to get creative. Don't let COVID-19 hold you back. You can still hold virtual sessions. You can still bring that content and deliver it in a different and innovative, unique way, and still continue to build and foster those relationships so that we can recruit more into our field.
I'd like to briefly chat about COVID for a minute. Aaron Odegaard, who is our incoming chair for the Council for Laboratory Professionals, works very closely with our chair, Tiffany Channer. And he's asking a question: have you seen healthcare disparities? Have any of you seen healthcare disparities as it relates to COVID testing? And if so, what are you doing to increase access to testing, or what are you doing to breaking down the COVID testing barriers as it relates to healthcare disparities? I'll throw it out for anybody. Feel free to jump in.
I would say, so in Baltimore, we have a large Spanish speaking community. And I think in the initial kind of peak of things, they noticed that we were having challenges with appropriately providing culturally and linguistically appropriate information. So there was a full front, full force, you know, comprehensive effort to make sure that literature was going out in appropriate language and culture, making sure that testing was done in culturally and linguistically appropriate ways. There were emails that were going out, task force that were made to make sure that our Spanish-speaking patients were being treated appropriately. One of the more significant issues was that patients were concerned about even coming in because of possible, concerns about immigration status. And so they were, Hopkins came up with entire policies about, making sure that our patients understand that there will be no repercussions for coming in, that they're actively encouraged to come in, and no one will be concerned about their status. So certainly that was a significant challenge for us with a large Spanish-speaking community.
Anybody else want to weigh in on that question? Dr. Brzezowski and Spostek?
I think one challenge we've seen is that because a lot of our screening is by telehealth, and this is not just COVID related, is that, and we've also looked at this with respect to like patient portals of how people can access their own test results. I mean, there's a lot of people that do not have access to broadband internet, other things. And so, if you make your predominant way of like, let's say triaging patients for COVID testing by telehealth, there's a lot of patients they're just not able to navigate it. They're not, and so, you have to have ways of doing it just by regular telephone, other ways. But I think that's an area of a lot of challenge, because the idea was you have telehealth in place to reduce risk, but then that may create other challenges in terms of language, in terms of internet access, other things. So I think those are things we're working on. That is a very difficult one that we've noticed here.
Any issues with COVID testing and inequality, Ms. Foster?
I would say similar. Here in the Kansas City area, we do have a pretty large or significantly large Hispanic, Latinx population here. And so that same thing, having material available or accessible that is in a language that can be interpreted and read. Even in the signage, if you go to a lot of the stores or a lot of the businesses, the please wear your mask signage is only in English. There's no variety in languages of that information being communicated in other ways. So I would say that's another layer or barrier. But creating more testing sites has been huge. Initially, we didn't have that many testing sites in the area, but I feel like we've exploded in a great way. And where we're providing testing, testing wasn't happening in certain parts of town, for instance, but now we're making testing more accessible in other areas throughout the region. So those are the few things that come to mind when I think about that.
Yeah, I think it's both. All of you have, I'm sorry, Dr. White.
I was going to say, I think another issue that we're encountering now is that a lot of these testing centers are drive-through, and not everyone has access to a car.
Exactly.
Yeah,
I mean,
that's true.
that diversity is important, where you have different, different perspectives. Like, did someone think about how people are going to get to the testing center? No.
It reminds me of an anomaly. ASCP works very closely with Puerto Rico as well. In fact, Dr. Dan Milner has been working very closely to support a lot of the forensic pathology debacles since hurricane. But recently, when I was working down there, the irony was they said, well, everybody has access to applying for, or you can, if you need money and from the federal government, just apply for money. Just go on the internet and apply for it. How do you do that when you have no power? How do you do that when you don't have access to the internet? How do you do that when virtually 75% of the island has been without power for close to 9 months? You can't just go online and apply for, just like you said, the assumption they're supposed to be able to read, right? We need to think a little smarter when it comes to how we interface with our patients, particularly when there's opportunities. So thank you all for sharing that. There is a great question. It comes from our past president at ASCP, Dr. Melissa Upton. And Dr. Upton asked, how would our volunteers, such as those on the Diversity Inclusion Committee, even within our own organization, ASCP or others, how would you help them develop effective training? What kind of links would they like to work with us as volunteers? Are there things that people can apply for in our volunteer portal? What would you be looking for as ambassadors to help broaden the spectrum and broaden the opportunities for focusing on diversity and inclusion? Give us some examples of things that we could do to support. Anybody? And I'm going to step in and help with so of course, part of the issue when you're dealing with diversity inclusion is a conversation around what's uncomfortable, right? So why not make what's uncomfortable comfortable? Why not have a conversation and put things out and ask folks to recruit or to serve in a capacity for us such that it will allow us to take on those uncomfortable conversations, whether it's around Black Lives Matters, whether it's around anything that we need to focus on our energies. Why not help us do that? Anybody have any other suggestions?
I would say at our institution, we started employing what we call community conversations, and each of them carries a different theme as it relates to diversity and inclusion. And I would say that's been really helpful in bringing us together as a community, even if we may have differing opinions or beliefs regarding to the topic per se, but it still puts us in that space of being uncomfortable and talking about it and voicing it, and kind of creating that camaraderie, I would say, and that just creating that safe space where we can truly share, I would say kind of be naked in a sense, emotionally, peel those layers back and just really address or take on the issues that we are facing as a community. So I'd say ASCP as a community, I think it'd be great to engage our members, our volunteers in those type of conversations, to once again kind of create that opportunity to share ideas and maybe gain more ideas through that process.
Thank you. So Dr. Upton wants to remind folks, for those of you who are interested in volunteering, any of you that are listening in the audience or those who are listening to recordings, please feel free to come through the portal, the ASCP portal. We have a diversity inclusion committee that is very, very task-driven, mission-oriented, but we're looking for bringing the conversation to the foreground. And we're looking for helping you and helping us make sure we solve these these issues around the conversation and around how we can make sure this organization continues to be diverse. There is a question for any of you, and I'll put it out there. Anonymous attendee asks, please address the exclusion of gay men from donating blood due to HIV, with short window of time it takes to detect virus by PCR, and the fact that many gay men take PrEP in order to avoid infections. This seems unfair and exclusionary. Please address this lack of inclusion. And it also feels like addressing gay men donating blood is sort of like the third rail of pathology. Nobody really wants to talk about it. Any of you want to comment on this?
I would say it like, and this comes up at our educational sessions every so often, and it's been something that's always bothered me, especially as the assays have gotten much, much better over the years. It just, there's also just been sort of a general, I mean, you can understand why criteria don't change quickly, but there's a sense that, you know, with some of the blood banking criteria, they take forever to catch up with where the science is, where society is and such. So this one has been a real frustration, yeah. And also the twist on this is that it became very complicated when you actually had this be a transgender patient. And you realize that the wording of it, the way it was worded, and there was no specific guidance on what to do in different transgender scenarios. So yeah, I don't know. To me, I think this is one that's really due to be, I would say eliminated, but yeah, that's a criteria that's been used, I mean, I think since the 80s, right? I mean, this has been, yeah.
I think he dropped out, but I'm a surgical pathologist by training, but I agree. I think, you know, the exclusion of gay men is I don't understand.
Yeah.
It's rooted in marginalization of a patient population, not in science.
So we need to do a better job as advocates, ambassadors for our profession to get the word out that it's absolutely okay and certainly expected for a gay man to donate blood, because the testing scenarios are so incredibly powerful today. Our ability to turn on quick results, that it allows for all of us to have an opportunity to support the needs of patients across the world. Really interesting question here from Stephanie Whitehead, who says that disparities can lead to distrust by minorities in the healthcare system. And in fact, African-American experience with vaccine and medical trials have really enhanced this mistrust. How can pathologists, laboratory professionals, particularly those in immunology, how can we work with clinical teams in order to help restore patient trust, particularly in the need for African-American involvement? And remember, the African-American involvement in even the upcoming vaccine trials for COVID, right? There's been such distrust in the past when it relates to vaccines in the Black population. How can we help break down this barrier and be advocates? Who would like to take this one? Dana?
I'll start with saying that that's where we also need to have diversity in the workforce represented. Unfortunately, for some of our patients or for some of our potential candidates in these trials, they need to see someone that looks like them, sounds like them, you know, sharing those facts or those updates, really, you know, acknowledging the experience. You know, let's call it out for what it is. Yes, that happened. Yes, that took place. Yes, it's a horrible, ugly stain in our history that still carries through. And it's not just in immunizations and vaccines, but also in blood donation as well. For a time period, you know, Negro blood was not acceptable for universal donation. And so acknowledging it, but also having that representation to be a part of this process is very important in getting in front of others.
And I'm going to ask Dr. White and Dr. Krasowski to comment on what Ms. Bostic just said. Let's start with you, Dr. White.
I think that the conversation about, you know, distrust extends again, like Ms. Bostic said, really deeply into our history, and lack of complete recognition of that history. I think currently we still see disparities in clinical trials across the board. Even now with, for example, drugs for cancer treatment, there are significant disparities in clinical trials leading to those FDA-approved drugs, potentially exacerbating any health disparities in twofold ways, where one, you have patients that are at increased risk of developing cancer not having the benefit of being in a clinical trial that would help them, but then secondarily, you're not testing a diverse patient population in your clinical trial. So I think, when we're thinking of health disparities in clinical trials, that's a significant area that we need to improve upon. And just, for vaccination, it's another element of it. I'm not an immunologist, but I think, we as pathologists are often involved with these multidisciplinary teams that are involved with clinical trial planning. And that's where we as pathologists and laboratory professionals can speak up and say, well, have we considered, our patient cohort? Are we thinking about, how we're doing outreach to our patient communities?
And I'm going to wrap it with that, because it is incredibly important to remember that as we do migrate closer and closer to a vaccine, it requires a diverse population of volunteers in order to make sure this works for all of us. Each of us needs to have access to that vaccine, and clearly it requires that all of our patients have the ability to break down those disparities. Thank each of you for your incredibly compelling conversations tonight. And we are beginning to wrap this up, and thanks to Dr. White, Ms. Bostic, and Dr. Krasowski for their insight. As I said in the beginning, having a frank discussion about equality in healthcare isn't easy. It's not always comfortable, but it's our responsibility as pathologists and medical laboratory scientists to raise our collective voices, to create an environment where we can discuss and have better care for our patients. To quote Dr. Martin Luther King, in the end, remember not the words of our enemies, but the silence of our friends. It's our responsibility to speak up. So before we sign off, I want to share some information with our audience. This town hall has been recorded. You can view it, or you can share it with your colleagues at www.ascp.org/town hall. It's also a subtitled recording of this event is available on the site as well. And the town hall is also available for CME or CMLE credit. So please claim your credit by going to the same site that you see on this link. And because of the ongoing pandemic, as most of you have been experienced, most annual meetings are going virtual this year. We invite you to join us on September 9th through the 11th for the ASCP 2020 virtual, which is going to be a one-of-a-kind experience for our members, one which will make you believe you're actually seeing each other as you're interfacing with your colleagues. You'll have a chance to connect with your global community as well, and not just partake in the unique educational offerings that we're going to be providing, but also feel like you're right there in that exhibit hall. This is an event that's free, completely free for ASCP members, and non-members can attend for a nominal fee. And if so, they're going to get a free year membership as well. So please find out more at ascp.org/2020. Watch out for the town hall page for details for our next town hall event, which is actually going to be on Wednesday, August the 19th at 8 p.m. Eastern Time, where we're going to look at where we stand in the state of COVID-19 in the U.S. With that, thank you to our panelists, and to all of us. Please be safe and have a great evening. Good night.
Thank you.
Okay.
Thank you.